drop off. Uh, Amy, Dr. Sears, Dr. Benoyer, I see others from our clinician work group, and anybody who's co-host, feel free to go ahead and admit people in if you don't mind. So we are going to talk a lot about, or not a lot, but we're going to touch base again about the updates on J&J today. We do not have any financial disclosures. We do offer CME, as always noted. Just have to email the address per usual here, covidcme.dhs@maine.gov. Just a reminder, if you're here, you know this, but if you want to remind any of your friends, we have switched to the second and fourth weeks of the month. It got a little bit goofy with this past Friday, but we will be on this Friday and then always the second and fourth weeks of the month. We'll continue to record and post. I mentioned we're going to talk about the updates with J&J, talk about clinical questions. And with that, I'll jump right in and ask Dr. Sears, you want to, so this
Sure.
is a brief recap of last week. We're going through the history.
It's a brief recap, and I couldn't, I want to just reflect for a second, which is, we've been dealing with a pandemic since 14 months ago or so. And every time we have one of these sessions or a clinical session, we always say, whatever we tell you today is what we know today. All of this J&J stuff has occurred in the last 2 weeks, just to put this into perspective. So this started on the 13th. Johnson & Johnson was identified as having a slight increase by the VAERS system through FDA and CDC of what was called cerebral venous sinus thrombosis, CVST, and increased clotting in cerebral veins. It was associated with 6 cases at that time. There was 1 death. That was out of about close to 7 million doses that had been given. Because of that, there was a pause that was put into place, and that was on the 13th. We now know that that pause was really to gather more data and for the ACIP to really look at things in depth, and that occurred last Friday, the 23rd. At that time, the ACIP evaluated this information, and it was actually a very thoughtful meeting in which they looked at the risks and benefits of COVID vaccination, what the real risks and benefits of the Johnson J&J vaccine were, and they determined that we should go ahead and lift the pause and continue to use J&J and use it, knowing that this is a very, very unusual but probable real complication that occurs, and one that we just all need to know about, so that if it should happen, we know how to treat it and treat it relatively quickly. The cases, as we could see, they identified a total of 15. That's going back and looking and scouring their databases completely. I want to emphasize, so far we do not have any of these cases reported in Maine. The thing that's important about this is it's not just a thrombotic syndrome, it is a thrombocytopenic thrombotic syndrome. Very, very similar to what we see with heparin-induced thrombocytopenia. And so with all of this, we restarted on the 24th, and we have begun to reuse J&J. A lot of small print here, but I think the important part is this is the thrombocytopenic syndrome. TTS now is what it's called, or some people still call it VITT, vaccine-induced thrombotic thrombocytopenia. It is laboratorily very, very similar. The first set of bullets is that the laboratory tests really look like autoimmune heparin-induced thrombocytopenia. There's a positive platelet factor 4, there's platelet activation, there's platelets activation inhibition by high concentrations if you give heparin, so that informs us not to use heparin for therapy. The clinical course is consistent again with heparin-induced thrombocytopenia. It seems to be an autoimmune phenomenon of some sort, but it's really unclear as to what the trigger is, because we know that there's been retrospective analyses of COVID itself to see whether there have been CVST with thrombocytopenia seen, or whether spike protein might actually trigger this, and it's been hard to show that. It's clear that something's happening. It may or may not be exactly the same thing that happened with the AstraZeneca in Europe, and there's a lot of research being done on that. And I suspect, in another week, 2 or 3, we're going to have the really smart scientists are out there and are going to be able to tell us really what's been going on. The most important thing is that if someone has had the J&J, or they present in these times with a thrombotic syndrome, specifically with thrombocytopenia, you need to have a high index of suspicion. You need to ask whether someone has had this vaccine, confirm that it truly is a thrombotic event, and there's thrombocytopenia. You can get a laboratory that includes platelet factor 4 immunoassays. If you have a hematologist to consult, that's great because they can help you with this. You do not use heparin. That's the key point, and that you probably use a non-heparin anticoagulant as well as IVIG, which seems to work relatively quickly in diminishing the autoimmune phenomenon, and the anticoagulation works for the thrombotic phenomenon. For those who want a really more in-depth analysis and review of this, there is today, this afternoon, from COCA, the COCA calls, which are set up by CDC, a clinical call, and Sarah Oliver, who is presenting part of this, did a really very nice presentation of this same information at the ACIP, which will go through a lot of the information risk benefit, and I'm sure she may well be adding to it by then. So I suspect this will be a really very good presentation. So what's the bottom line is that there's the benefits really do appear to be effective with a single dose, and it outweighs these known risks. We really do continue to face a deadly pandemic with the potential advent of variants. All we need to do is see what's happening in some of the countries in the world to see how deadly this can become. And we're running against time trying to get people vaccinated. The Janssen vaccine seems to be a very effective tool in our toolbox, along with the other vaccines, to use to protect against this disease. It's simple to use. It's a one-dose shot. There are concerns as voiced in the ACIP that any restrictions would have significant proportion of the US cases not being vaccinated. So I think that there is a commitment by both the federal CDC, by Janssen, by everyone to continue to look at this in great detail to see if there's any other further concerns, further information, and or therapeutic and diagnostic choices we need to make. But I think we've come a long way in those 2 weeks. And a lot of that is because of this system. And I want to give another plug. Anytime you see an individual you've given a vaccine to, or they've had a vaccine and they haven't, a reaction, something that seems to be out of the ordinary, report it to VAERS. It's better to report it than to not report it, especially report these cases though. And this is the information on how to use this system. So we are restarting. It's surprising when without using it, we were starting to see a significant decrease in the numbers of J&J vaccinations. Getting it back into the circulation, I think, is critical for certain populations. There will be people who question this, but a lot of people are understanding this, and they are taking it. I think the key messaging is that this was a pause, and an analysis of the information and a re-release. The vaccine is extremely safe. It remains extremely safe. This condition is less than or about 2 cases per million doses vaccinated, and the safety system really did work. So we want to use J&J where it is appropriate. And I will let Lisa, you take over from here.
Yeah, thanks, Steve. So just following up on that, I think there's been a lot in the press lately about, well, what do you say to patients? So those are some of the key messages there. We also have Dr. Tom Frieden, former US CDC director, who heads up a nonprofit trying to promote vaccines. So some other suggested messages from him that have shown up in several of the media releases recently. So just stressing the effectiveness, and we've talked about a lot of these before. I think this is an interesting one I hadn't seen before. If we can get more people in the US vaccinated, we can prevent up to 100,000 or more deaths. Doctors who people trust have really expressed a high confidence. I think the number is over 95% of doctors have taken the vaccine when offered. The growing amount of evidence about potential long haul, not only immediate, but long haul complications from COVID. and the old, when we get the more we get vaccinated, the sooner we get back to normal. So just some thoughts again about messages that you can use in your conversations with patients and friends and neighbors. I think you're all aware, are opened up to 16 and older. And as part of that, we continue to try efforts to promote equitable vaccine distribution. The pop-up clinics were paused a bit. So this is an effort by the immunization program and DHHS uh, equity efforts to get vaccine into high-risk communities. You've seen this before, but they were using J&J, so that got paused as well. But we are putting sort of another big push this week. Anybody who is in communities that have higher populations at higher risk, particularly racial ethnic diversity, to apply for one of these pop-up clinics. Additionally, we continue to host these webinars on the third Wednesday. So we just had one last week, but May 19th, we'll be talking more about best practices and methods for engaging communities and building confidence. And then a new update that just went out last night for the closed access, the distribution sites, so the large vaccine sites. We are encouraging sites now to accept walk-ins. We know most places are now seeing no-show or cancellation rates of upwards of 20 to 30%, and we think that making access as easy as possible can be one way to really get those numbers back up. I shared on the vaccine work group call last Thursday what I thought was just a fantastic idea from Chris Bovey at Midcoast Hospital. They literally have given what they call a golden ticket, a piece of paper to primary care practices, and said, look, if you, in the course of a visit, the course of a conversation with a patient who has some hesitance, if you are able to get to a point where they accept the vaccine, you give them this ticket and tell them you can walk right over to the vaccine site, whether it's down the road or across town, and they will get you in right there. So that notion of, leveraging the relationship with a trusted source, primary care, of giving somebody, a sense of being special and lowering the barrier, right? You not, go call this number or go register online, but you can get in right now. So I just wanted to share that because I think, and they've had really, it sounds like really good luck with that. Additionally, the state just announced last night that we'll now support special point of distribution clinics for workers. So for workplaces, particularly those that have a workforce that are increased COVID risk, as well as for students in settings of higher education, though such clinics would have to be planned within the site's regular vaccine supply. So there's not sort of a newer extra source. We are still hoping for those vaccine supply numbers to go up, and that's been a struggle with all the different changes over the last couple of weeks. We also still have the mobile van. So just so folks know, that will, I think we're about 3-4 weeks into it. So for another month, maybe longer. It's currently in Biddeford. Next week, it'll go to Freiburg, and then Turner typically is in a spot for between 3 and 5 days. They did pause J&J, but they're offering it again in that week in between or so. They did use Moderna. We're still figuring out how people will get the second doses, but we thought it was more important to keep that going. Vaccinations are generally by appointment, but we have opened up to walk up at most sites. And I think we just heard yesterday that will be available next week as well. They've been doing about 300 to 500 vaccinations a day, and people can sign up through the line, or there's a new, I think I've mentioned it before, but we kind of had to put a pause on that. The state registration site, vaccinateme.maine.gov, people can sign up online as well. We've talked now a couple times about the vaccination line, so just a reminder about that, as well as the transportation assistance. We have passed the 1 million mark in Maine, so that's very exciting. And just always more information on the governor's website. Just a reminder for anybody who joined late that we are now in our twice monthly, so second and fourth weeks of the month. And I will stop sharing for questions. So any questions teed up here? And I'll also put from the slides, I'll put in the link to the COCA call that Steve mentioned a few minutes ago. I'll just put that in the chat. So let's see here. Amy, you got any teed up here?
Yep. So one question is just about the CME certificate process, Lisa. Some people have filled out their surveys, but not gotten a certificate. So I don't know if you want to talk about the process again.
Well, it's supposed to be that about once a month. So when you guys email, it goes to an office at DHHS. One of our support folks tracks all those, sends it to the MMA, then they send you the survey. So if you got the our little evaluation form, then you're supposed to get a certificate. So if you have not, if it's been, I'd say more than a couple of weeks, I would suggest you email Gail Began at the MMA, and I will put her email in the chat here. But I'd say give it a week or two after you've completed and sent it in, because I know she's got a lot of folks that she's working with on this, but I will put that in right now.
Are there any handy comparisons on the risk that might help people put this at a small level in perspective, like it's more likely to be struck by lightning or killed in a car accident and have one of the side effects from J&J? Is there any sort of thing that you've seen that people might understand?
I have not, but I think there are some around. Lisa, I don't know whether you've seen anything that specifically gets to the kind of putting on your seatbelt, how often you get, all those sorts of other comparisons that people make. I've not seen them in a chart though. That doesn't mean
Yeah,
they're not there.
I've similarly seen references kind of in lay press. Laura Blaisdell participated in our equity webinar last Wednesday and cited several of those too. We'll have to, maybe we can put that on the list for next time and see if we can come up with a helpful resource on that. So it's an interesting idea. I'm always curious how much that, does it move people? We'll have to get more information about that. So to follow.
Are you seeing any variation amongst healthcare provider vaccination status, nurses versus doctors? And the question, I think, is really an earlier suggestion around being more inclusive about healthcare providers when noting those getting vaccinated. So as a nurse practitioner, they consider themselves a trusted source of health information. But then the second question is, have you seen a variation amongst different types of healthcare providers and their willingness to get vaccinated?
So one is who's a trusted, sorry, I'm just copying the other one, a trusted source.
One is broadening
Yep.
the message about, doctors will take the vaccine 95% of the time to healthcare providers. Yes. The second question is there variation amongst nurses versus doctors versus other healthcare providers about willingness to take vaccines?
Yeah, so apologies for that. And I do try to generally be inclusive. I was citing advice directly from Dr. Frieden, so I was just quoting that, but I would completely agree that other providers, particularly nurses, often come up even higher than physicians as a trusted source. But in terms of that 95% of doctors, I think that was an actual poll of physicians. So I was just citing that.
Yeah.
In terms of, other groups who, where there's variation, actually, I think, unfortunately, there has been a fair amount of variation among nurses, particularly, I think many of them younger, and some of those issues are fertility. So I think acceptance levels varied significantly. I don't know, Steve, if you're gonna.
Yeah, no, I was going to say, I think it's part of the problem of lumping everybody and everything together, so that what you find is acute care nurses tend to have higher rates of uptake than long-term and chronic, long-term care type nurses, and that's been that way for a long time for other vaccines. There's probably a lot of dynamics involved in that statement, but that appears. So I agree. I think it's variable around the country. Maine has, from what I can tell, had a higher uptake among healthcare providers than some other parts of the country have done with this.
Next question is, do you have any updates on vaccinating the jail populations?
So remember, in our state, we have within the Department of Corrections, both the state prison system and the county jail system. So within the state prison system, which is, Warren and others, where people are typically there a year or longer, there have been successive waves of vaccination efforts with the governor's age-based strategy, and I don't have a today update, but I believe they've just continued to offer vaccine as eligibility has expanded. The county jail system is significantly more challenging, both because those, they're run by each county, by each sheriff, and it's ultimately up to them. It's also many people there are also there for a much shorter period of time. So the use of the 2-dose vaccine 3 and 4 weeks apart tends to be very tricky. So there have been conversations with the various sheriffs. I think I just heard Cumberland County is going to do a round of offering J&J. I believe I just heard that coming
Yeah,
up
they
soon.
were
There's been several
actually
outbreaks.
offering it, and then when the pause happened, so they've been very proactive. But again, their average length of stay is 12 to 13, 14 days, somewhere in that range. So the 2-dose shot was not working for them. So they are getting J&J back.
But it does vary jail to jail and what different counties, how they've approached it. So
This one is,
uh,
they're concerned about decline in demand for vaccines. This person volunteers with Northern Light at one of the clinics in Fairfield. They said they're cutting back clinics from 3 full days to 1 half day a week. Do you have any thoughts on that? In terms of just generally, there's more news about some of the rural sites cutting back hours and days.
I think they're trying to adjust staffing and resources to meet demand. So, I think it's not entirely surprising. I don't know, is Jim, I think Jim's away this week, isn't he? I don't know if anybody else from Northern Light is on who specifically wants to comment.
I also know that or I've heard that the Maine general sites are cutting down in the next couple of weeks in the Civic Center in Augusta, again for a declining demand. So, I mean, what that tells us is we have to continually assess what's going on as far as demand, try to find ways to provide accessible messages, and continue to, I think, as Lisa, you said, is diminish barriers so that this can become is really easy for people to do, so that there's nothing that stops them from doing it if they've got it near them and available.
What happens if a
Yep.
patient makes an appointment at a clinic and gets there and it's offered J&J and they don't want it? Will they be set up with another site that offers Pfizer or Moderna?
I mean, they certainly would be offered that. It's clearly, their choice. So, I mean, the good and bad news right now is there's not a ton of J&J here again, other than what the mobile van had. The state has not got an allocation for the last 2 weeks. But, when that becomes more plentiful again, yeah, I mean, I think it's whatever people are willing to get. They would not, certainly at the mobile clinic, be just offered Moderna right then. They'd be encouraged to, call and set up with a different clinic. So, there's going to be the administrative challenge of that. I don't know, again, if anybody's on, Peggy from the Maine. I know you've done a lot of work with the Maine Health Clinic or others, if you want to jump in, how you guys are handling that. Although, again, I'm guessing most places do not have J&J right now, but anybody thoughts about how
Yeah,
you're handling that?
this is Peggy. I agree, Lisa. I think it's more what's on site and what's closest to your arm.
But ultimately, it's their choice.
Right. And if you go to like Walgreens or the Northern Light site, many of the sites are now putting on what type of vaccine the appointment's for, knowing that that may change, but they're getting much more specific about what's available and what they're signing up for. So how long can the
Yes.
second Moderna dose be delayed before losing efficacy?
In the federal CDC guidance, it suggests that you should try to give the second dose within 6 weeks. Having said that, and I'm going to take this away from what is actually said in guidance and then make some hypotheses based on what is reasonable immunology, is it probably can be upwards of a couple, 3 months. That's what the types of, not Moderna, but Pfizer was delayed in England. England used a delay strategy using single doses, trying to cover population with whatever vaccine they had. And they had AstraZeneca, they had Pfizer. I don't think they had J&J at the time, but anyway, and they've gone back 3 months later and have been giving second doses, and it appears to be an effective strategy overall. And Peggy probably knows more about the immunology part of that, but there's a lot of vaccines that we think about, like hepatitis B vaccines, where we or hepatitis A, where you might give it like several months later. You clearly need to prime, and then you need to then have the booster or solidifying effect.
Just as a reminder, so when we've got the 3 and 4 weeks right now for Pfizer and Moderna, it's not because there was data that said that that was the best time to give it. They were trying to do the trials. They were giving it, their best guess, their best shot. So that I don't believe we have any data that it loses efficacy after a certain period of time. So we don't
No,
know
we
yet.
don't. And
And
as I
we don't
said,
even, maybe longer is better. We don't actually know yet.
yeah, there's actually some people who think that in the immunology world, and there's, as I said, the experience in England will be very telling, but it appears to be very effective. And England has some of the rapidly declining rates because they've done such a good job in covering population with any vaccine, and one to start with.
Great. Dr. Penoyer, anything you want to add to that?
No, totally agree. I mean, I think it was just the urgency of getting that second dose in with the pandemic. Otherwise, several months is fine. And the CDC guidelines do iterate that even if you can't get it in before 42 days, you can go ahead and give the vaccine and not have to repeat the initial dose.
Great. Okay. Anybody else? Questions or anything that you want to share? All right. Well, we will be back on the second week of May, which I just, what is that, May 11th? And if folks are asking again, we will be back on at noon this Friday. We'll post the recording, and to thank everybody for joining, and see you next time.